So I'm going to be talking today about respiratory failure. So respiratory failure can be divided into two main things, but one is going to be chronic and the other one can be acute respiratory failure. So that's really one of the key main things. I'm just going to give you guys a bit of information as to, first of all, what is the definition of respiratory failure. Respiratory failure is essentially when there's going to be long-term impairment to the respiratory functioning or its system. So what does any of that mean? So when there's long-term, so that comes from chronic, and it's going to be causing impairment. So impairment of what? So impairment of essentially the functioning. What's the main function of the respiratory unit? It has many functions, but main function is that it gets oxygen from the airways, takes all the way to the alveoli. And when it takes it all the way to the alveoli, it essentially just causes gas exchange. So let's just imagine this box over here is going to be our blood vessel. It causes gas exchange. But when you have some sort of a problem, there can't be enough gas exchange. So what I mean by that, it normally causes O2 to come in and CO2 to leave. So you can get less O2 because it can't get O2 from the environment, and it can't get CO2 out. So that's why you're going to have hypoxemia and hypercapnia. That's one of the main key things. So what's the next thing I've written over here is going to be that it affects pathophysiology. It affects the pathophysiology of the carbon dioxide and the oxygen. You're not able to exchange them anymore. What's the cause of this? The cause of this can be due to COPD or some sort of restrictive disease. So it can be either due to obstructive disease or restrictive disease. Obstructive can be COPD, so chronic obstructive disease. Two types of obstructive disease, one is emphysema and chronic bronchitis. We've shown emphysema over here, that the alveoli are now much more bigger. Over here they're much more smaller. So there's much more less surface area. You can only gas exchange in one alveoli. But over here you can gas exchange in one alveoli. Over here, another here, another here, another here. So many alveoli, less gas exchange here, more gas exchange here, less over here. That's from restrictive disease. You're gonna be really infiltrating the interstitium with a lot of fibrosis. And what's the main complication with respiratory, like some sort of restrictive disease, is you're reducing vital capacity. What does vital capacity mean? Vital capacity means inspiration and expiration. It means both of that. So you're breathing in and breathing out. That's your vital capacity. So you're going to be really going to be decreasing your vital capacity. And that's how does vital capacity decrease? Well, that's going to be due to some sort of that can be due to some sort of pneumonia. So when you get inflammation, or how else can you get fibrosis? When there can be idiopathic, so unknown reasons. There can be due to your inhaling pneumoconiosis, which basically means you're inhaling organic dust particles from the environment. So if you inhale too much dust particles, your cell, there are macrophages present over here. That's like the only cell apart from the alveolar cells present over here, and that leads to inflammation. Now, what else can we get? And so that's about it. What we want to talk about chronic obstructive pulmonary disease. That is a long-term thing. It causes these type of problems with the CO2 and O2, and it can be due to COPDs, so chronic obstructive disease or restrictive diseases. Second type of chronic respiratory failure is going to be our it is not second type. It's going to be basically the same thing. And this is also due to the fact that I want to point out that it not only affects your alveoli, it can also really go and affect your airways. So if you go back to this diagram over here, your airways also be affected. So there's some sort of narrowing or obstruction or some sort of circle, like I've drawn a circle over here, in the airways that can lead to some sort of respiratory failure, like this circle. So you can see there's a circle over here. That's really just obstructing the air gas exchange, so that's really a big problem. And not only that, but there can be the narrowing. So narrowing is when there's mucus, so that can be in chronic bronchitis. Chronic bronchitis is when you have cough basically for a long time, so 3 months or more than 2 years, 3 months over a period, more than 3 months over a period of 2 years, and it can accumulate as mucus. What else is also here? Your normal mechanisms. What happens is that your normal defense mechanisms, whether that's mucus, so where you trap bacteria into mucus, or there are problems with the cilia, so you can't beat stuff out. and you can't beat stuff out. So the cilia beats upward mucus, so you can swallow it. And another mechanism is our carbon dioxide. So when carbon dioxide comes into our body, it's going to be in our blood. So when it's really accumulating in our blood, what happens is we can go and take it to our blood-brain barrier. So I'll just show you guys a photo over there. So our blood-brain barrier right over here. Yeah. Blood-brain barrier over here. It brings carbon dioxide over here. And carbonic anhydrase is an enzyme which is mainly present in every single cell, I would believe so. And it can convert carbon dioxide into H plus and bicarb, and H plus can then go and trigger the medulla and oblongata, and I'll show you exactly the medulla oblongata. So again, copyrights to this, whoever's picture that is, Media Lens Education, and they basically showed medulla oblongata on the ventral surface. And so like I was showing that, it was showing the picture that bicarb and H plus is the main thing which hits the chemoreceptors, which are known as central chemoreceptors, not peripheral. And that really leads to high. Then from here you can imagine with these nerve fibers then hit the lungs. So this is a better picture. That these are the H plus hits it, and these wires hit back at the lungs, and that causes hyperventilation. Hyperventilation, so you're removing the carbon dioxide. So when you have no hyperventilation, so your control of CO2 is not there, when you have no mechanism of defense, then you develop some sort of a respiratory failure. When you have the disease, so we talk about disease, COPDs, and interstitial fibrosis, and not only that, you also have compensatory mechanisms, so you're having hyperventilation or you're having these mucus. That's what leads to chronic respiratory failure. So it's a combo of these two. What happens is the main thing that it affects is our blood gases. So our blood gases that are being affected are going to our blood gases are going to be normal, going to be quite abnormal in when you're resting state, but when you're exerting or when you're putting exercise or you're running or like putting effort, that's when it really gets affected, because you already have low oxygen. When you're running, you're really an anaerobic glycosis. You're getting less oxygen, you're not able to take enough carbon dioxide, and that's really affecting you. And you're not really taking, and that can really build up CO2 and reduce O2, which is something you don't want. Acute respiratory failure is an emergency. What do I mean by emergency? This means acute. Again, same thing, that you're getting low O2 and low CO2, but acute respiratory system in comparison to chronic respiratory failure. Acute respiratory failure in comparison to chronic respiratory failure can be divided into two things. So it can be developed to hypoxemic or hypercapnia. What does any of that mean? So hypoxemic, which I mentioned over here, is the one that is the one that really tells you that there is hypoxia, but you're having normal CO2. So your O2 is less, but your CO2 is good. Hypercapnia, which otherwise known as global respiratory failure, is when O2 is less, but CO2 is very high. So that's the main thing. Another thing I totally forgot to mention about acute respiratory failure is that what are the values? So when we're speaking about arterial blood, these are normal values. So I need to move this on the side. Arterial, you're normally like a normal human being, is 95 millimeters of mercury, and I forgot to mention here, but 40 millimeters of mercury in the arterial blood. But what can be the values that you might see in a patient with this type of acute respiratory failure? He's going to have pretty low oxygen, but very high carbon dioxide. So that's key finding. And now we're going to be talking about partial. So why is this partial? So I guess the main reason why I call it partial, because it's only affecting oxygen, not CO2. So where can we get this? So that's the main definition, hypoxemia. So when you think about partial acute respiratory failure, think about hypoxia, and that's half the thing, but normal oxygen. So that can be normally when we go into the on top of the mountains and on high altitudes, and we're getting low oxygen over there. Then the next thing can be some sort of small respiratory disease, such as like pneumonia, or I'm not sure about. Sorry. Yeah, I was talking about partial hypoxemia. Yes, sorry about that. What's the definition? Is when you have hypoxemia or normal capnia, normal carbon dioxide. And I talked to you guys about the two causes. If you're high in the mountains, or if you're having some sort of respiratory small like a respiratory disease, which is like pretty is less severe to be. A global or a hypercapnia respiratory failure is essentially occurring when you have low oxygen and obviously high CO2 in the blood. That's what is caused. So you can have a severe respiratory disease. The causes can be divided within the pulmonary system or outside the pulmonary system. So outside the pulmonary system can be any sort of problem with our respiratory center which you have. So your respiratory center depression, so it could be due to trauma or some problems, or you're going to have pure hypoventilation when you have some sort of chest injury. I believe another thing which I'm not sure about is I think Guellain-Barré syndrome. Guellain-Barré syndrome is when you're having demyelination, which I believe is autoimmune against your neurons, your axons. The axon, which obviously is surrounded by a myelin, so you're having problems, you're having destruction of the myelin. And then these neurons or these axons go and innervate the respiratory system, and obviously now you're not getting hypoventilation because you have no neuronal control over your muscles, respiratory muscles. So that's interesting. Intrinsic is going to be some sort of respiratory disease such as pulmonary embolism, or so you're just a DVT that goes in your pulmonary artery. Pulmonary artery, if I could make that a bit bigger, and yeah, the copyrights for this is from Drug Watch, I believe, website or something like that. Is that the copyrights? And it goes in these pulmonary arteries, and that's where you get this problem. The clinical symptoms are like many. So it's going to be clinical symptom. Respiratory failure is not like a very simple thing. It's like a combo. It's a combo of low O2, high CO2, and obviously depending if it's chronic or acute, and the respiratory disease. So if you're having pulmonary embolism, the symptoms are a bit different from those which might have pulmonary edema or that's the key that you need to know, that it can be a bit different. Sorry. Another thing is going to be clinical. So obviously I've divided the clinical symptoms into hypoxia and hypercapnia, which I'll get into. Hypoxia, you divide it into what are the symptoms in the CNS, what are the symptoms in your heart, what are the symptoms in your lungs, obviously, and pulmonary symptoms, and what's going to be the symptoms in your systemic or the blood vessels. CNS is like pretty you'll feel like tired, I guess, because now you're getting low metabolism. That's the reason. Because obviously you have low energy, basically, I would say, so because you're having low CO2, so you're not able to generate not enough ATP, so you're going to be having these type of symptoms, and you're going to be having confusion, maybe a headache. Another problem which you might have is agitation and restlessness, and that's because maybe you're having an electrolyte, maybe due to electrolyte imbalances. I'm not 100% sure about these last two, like restlessness and headaches. Heart disease can be due to tachycardia. Why are we having tachycardia? Because what's the reason behind that? Because your aortic bodies are being stimulated. What even is aortic body? It's on your aorta. So if I have a picture of aorta or something here, is this a picture of aorta? Yes, aorta. So aorta bodies will be present somewhere here. It's a chemoreceptor, so chemoreceptor for O2, a baroreceptor for blood pressure, which is not important here, and I believe it's something else which is not really too important right now. So it goes to your medulla oblongata, and it hits your medulla oblongata, and then you get a response back to your lungs, where you have to a response back to your heart. So where's the heart? Heart's not here, so back to your heart, and it hits your heart and tells you to go tachycardia, to increase cardiac output, increase stroke volume. Pulmonary problems can be vasoconstriction or pulmonary hypertension. What's the reason behind this? What's the reason behind pulmonary hypertension? Because your blood, everything is being shunted down, everything is being closed down, your pulmonary artery is being closed down, and you go into other areas. But systemic symptoms are going to be blood vessels. So you're having less O2. So now what's going to happen is you're going to go anaerobic metabolism. Sorry for my spelling. Yeah, sorry for this. Yeah, basically you're not going from glucose to pyruvate anymore. You're going from pyruvate to lactate. So pyruvate to lactate, you're accumulating lactate, and it's going to go lactic acidosis. Similar over here, prerequisite for hypercapnia is that you need to have it will always have hypoxia symptoms. Other symptoms is that it can really it'll hit the central chemoreceptors. It hit the central chemoreceptors, and And yeah, that's about it. And one more thing is that it can cause respiratory acidosis due to increased CO2.